It is now time for our panel of experts. Please welcome to the stage Tom Kornfield, founder and CEO of MAST Health Policy Solutions, Amy Niles, Chief Mission Officer of the PAN Foundation, Dr. Gary Puckrein, President and CEO of the National Minority Quality Forum, and Julia Schreiber, Program Director of Maryland Department of Aging and Administrator of the Maryland State Health Insurance Assistance Program. They are joined in conversation by Editor-in-Chief Bob Cusack.
Okay, so two great discussions set us up for this panel. We can delve into a lot of issues, but why don't we go down the line, Tom, starting with you. There's a saying in journalism, don't bury the lead. So if you can have a short intro, and what's your lead of the day? What's the one takeaway you want the audience to take away from this discussion?
Do you mean the discussion just generally around the changes for next year? Or
yeah,
what?
Just whatever you think is the most important thing to convey.
Well, I think that the most important thing to convey is the benefit is changing tremendously in terms of the out-of-pocket cap, and I think we heard about the monthly prescription payment plan, or MP3, it's sometimes called, or M3P. I forget what the right acronym you're supposed to use is, but it's basically an installment plan, right? And I think that protection for enrollees, I think, is one of the major changes for next year. The other, I think, is just given there were a whole lot of other changes in the benefit without going into a lot of details on it. Essentially, plans are at higher financial risk for their costs than they were this year. So that has led, I think, to a lot of changes in terms of plan availability, in terms of premiums. So I think that's where it's really important for folks, as I think we heard earlier today, to shop around and make sure that they're looking for, whether or not their medications are covered, and also, what their premium is.
And a little bit about yourself.
Oh, I'm sorry. So I'm Tom Kornfield. I'm the CEO of MAST Health Policy Solutions. I spent about 25 years working on Medicare Advantage and Part D policy. Spent 10 years at CMS, where I was in charge of the division that did, for some of that time, that did Part D payment policy. Worked on the implementation of the Medicare Modernization Act in Part D, and have worked on risk adjustment payment policy for quite some time, and also spent some time at AHIP in Avalere.
Hi, everyone. I'm Amy Niles. I'm Chief Mission Officer with the PAN Foundation. The PAN Foundation is a national charitable foundation and healthcare advocacy organization, and we are here to accelerate access to affordable, equitable healthcare. We do that in three ways. The first is providing financial assistance to individuals who are underinsured so that they can start and stay on treatment. Secondly, by advocating for patient-centric policy solutions like the Medicare reforms that we are talking about today, so that we can enhance access to care for Americans. And finally, educating patients and healthcare providers about very complex issues and how to navigate a very complex healthcare system. I think one of the key messages today is the importance of open enrollment. There never has been a more important time to evaluate one's plan. We have about 2 million plus seniors who are facing plans that are no longer going to exist in 2025, or major changes to their plans. So it is really important for people to take the time. And we know that for the most part, 7 out of 10 seniors are not taking time to review their plan. So that is an important message. At the PAN Foundation, we did a national poll of people on Medicare about 2 months ago, and we found that 9 out of 10 individuals were not aware of either of the two reforms today. The Medicare Part D cap, which is automatic, that's an easy thing. People don't need to do anything, but the Medicare prescription payment plan, and that's a mouthful, and we used to call it M3P or MP3 as well. But the Medicare prescription payment plan on the surface sounds simple, but it is complicated, and it may not be for everyone. But during an open enrollment time, this is the time for an individual to evaluate whether the Medicare prescription payment plan is right for them.
Gary?
Good morning. I'm Gary Puckrein. I'm president of the National Minority Quality Forum. We are a research and education group based here in Washington, D.C. I'm going to say a lot of discordant notes for you this morning. I'm sorry. I don't believe in government price control. I went to college. I took one eco course. I hated it. But the only thing I got out of that eco course is government price control brings a whole set of problems. And that's what we see in the Medicare program. Medicare does not follow the science. In healthcare, everybody has to follow the science, right? You go to FDA, you got to show safety and efficacy. You come out of FDA, you got your drug to the marketplace, and then CMS flies in with a set of rules that are not associated with safety and efficacy and outcomes for patients. In fact, CMS doesn't even tell you about the outcomes of policies that they make. So let's dive in a little bit on this smoothing. This is what we call this loan. So I grew up in the hood, right? And so we had these loan stores in our community. And so the first question you have to ask yourself is, so what happens when you don't pay the premium, the loan back, right? Because as I read the law, and you guys can go take a look at the CMS rules, they stop your medication, right? So that's what the rule says. Now you can go read it. They stop your medication until you pay the premium, until you pay for the drug, right? So here you are, an individual, you've got cancer, very expensive drug. Somebody comes and says, hey, you can get the loan, right? You go get the loan, and the bill comes due, and you can't pay for the medication. And what happens? So what CMS has done, because to take the risk out for the plan, they gave them $5 billion. I mean, that's what I read going on. So here's my point. My point is, we have to begin to back CMS out of the marketplace in healthcare. We have to figure out, how do we do what Americans do? Have a competitive marketplace in healthcare. I know that sounds really difficult and contrary, but I think that's the way we got to go. Because at the end of the day, we're spending $4.5 trillion a year in healthcare. That's the number, $4.5 trillion, which is larger than the GDP of Germany. Larger than the GDP of Germany is what we're spending on healthcare, and we get poor outcomes. So anyway, I'm just giving you my discordant note that it's time to reimagine this system, because the one we got is completely broken. Thank you.
Julie?
So I'm Julia Schreiber. I'm with the Maryland Department of Aging, where I'm the program director for the State Health Insurance Assistance Program. We help beneficiaries, their loved ones, families, and caregivers navigate the complexities of Medicare. We're also the Senior Medicare Patrol, so we help beneficiaries navigate Medicare fraud, errors, and abuse. And we do this through partnerships with local area agencies on aging throughout Maryland to provide that localized counseling. And I would just reiterate, and every year we say to beneficiaries to review their annual notice of change that outlines how the plan might change from year to year, and to connect with a counselor if they're interested in seeing what other options are out there. And then I would also just emphasize asking and looking into financial assistance programs, because there's a lot of programs out there that can help cover the cost of Medicare that are actually underutilized.
Amy, I want to go to you. You've done a radio tour in New York City trying to reach patients on this topic. What did you learn?
Continued lack of awareness about the reforms. I mentioned our poll, 9 out of 10 people on Medicare throughout the country not being aware of either reforms. And I heard similar comments on the 26 interviews that I did with radio stations throughout the country. But regardless, it was an opportunity to educate. Again, the Medicare Part D cap is automatic. And if you are someone living with a serious illness or illnesses, and you've been historically used to very high out-of-pocket costs, that $2,000 cap is welcome news. Albeit, it is still quite a bit of money for many Americans. We did research at the PAN Foundation a couple of years ago to validate that even helping millions of our seniors and people on disability, it is still going to be a struggle for many communities. The Medicare prescription payment plan is important. It is not for everybody. It is not a loan. It is an opportunity to spread out the cost throughout the benefit year. And if someone unfortunately cannot pay that bill, we're encouraging them to make sure they are paying their premium first to keep that drug coverage. And so we're trying to simplify the Medicare prescription payment plan because it's complicated and there are behavioral changes. So someone needs to do something to benefit from the payment plan. They need to call their Part D plan, or they need to go onto their plan's website to take action to participate. And the best time to do it is now during open enrollment, so that you have more months to spread those costs. And secondly, if someone opts into the program, they're not going to pay for their prescriptions at the pharmacy counter, and that's a big change for people on Medicare. They're going to get this bill from their Part D plan. So there's a lot of nuance to this and education that is needed.
Julie, just want to get kind of the same question. What's the feedback you've gotten in Maryland? What's the best way to reach seniors? My dad's on Medicare, and unless maybe there's a commercial during a Mets game, he's not going to really be paying attention. But what are the successful strategies that these stats about 6, 7, and 10 don't know what's going on? That's daunting.
Yeah, so through the State Health Insurance Assistance Program, we do a lot of outreach. We partner with older adult housing facilities and go and do presentations there, senior centers. So there's a lot of just education and courses that happen in partnership with some of these other facilities where older adults are already congregating. And then, there's a lot of Medicare Advantage marketing out there. So just doing some of our own media outreach, whether it's bus wraps or radio interviews. In Maryland, we're also partnering with 211, which is our Maryland Information Network. And so they are regularly interacting with a lot of Marylanders, and it's another way to get the word out. So it's finding those places where people are already going, educating some providers and people that are already sharing information about some of these changes so they can share the information as well.
Tom, you're an expert on Medicare Advantage as well as Part D. What are you watching for these programs in 2025? Also, noticed you had a few head shakes from what Gary was saying, so I want to give you a chance to respond.
Well, I mean, I do think there are a lot of changes in terms of what plans are going to be offered. So I think 7% of Medicare Advantage enrollees are in plans that will be terminating this year. So there will still, I think for most of them, and my parents actually are in one of those plans, as it turns out, because my mother sent me one of the picture of the notice that she got, and she's like, "Did you expect this?" I'm like, "Well, I heard that it was going to happen. I didn't know, it was going to happen to you, but I had heard that there might be some disruption." So there's that. There's also, as Amy was talking about, there's 2 million some odd people in plans. I think a lot of them are in some of the larger standalone prescription drug plans. That are they're actually moving their folks into I think in CVS. So it's CVS and United, and CVS is moving folks, I think, from their enhanced plans, which were sort of there was one plan that had a low premium, one plan that had higher premium. They're moving them into what's known as a basic plan, which is kind of the standard Medicare coverage. And then there's United that's moving folks from one of their plans into another plan. So they're going from 2 plans to 1 plan. So, absent any action, those folks, I think, will roll into that new plan. So I think that's where it's incumbent upon folks to, Medicare.gov allows you to look at, premiums. I know it can be, there can be challenges, but nonetheless, I do think it's a really important tool for folks to use. No, I mean, my understanding, I guess, just kind of going back to some of the comments earlier, um, on the availability of drugs. I mean, I don't believe you can be. My understanding is you cannot be disenrolled from a. You can confirm. I'll look at Amy to see if it's right, but you cannot be disenrolled from your Part D plan for failure to pay your copayments. Now, in terms of not getting your medications, I suppose, if you're not paying your premiums, then there's a process by which you can be disenrolled, and that's not new. That's been there since the start of the Medicare Part D program. So I just kind of did want to push back on that a little bit. It's not true that you're not going to be able to get your medications if you're not paying your copayments. The plans will try to, collect that information, but one of the concerns that I've heard from the plan side actually is concerns around bad debt, because they're concerned that they won't be able to collect that information potentially and will have to write it off as bad debt, and that could impact their premiums. I think the other thing that has kind of been in the news in the last week or so, a couple of the major Medicare Advantage plans have noted, the challenges in terms of what their healthcare costs have been relative to what they were expecting them to be. So I do think that there are going to be pressures, and I think we heard Bruce talk about concerns around overpayment. I think that's going to continue into next year, and obviously with the tax cuts expiring, and I think there's going to be an environment where folks should be talking a lot about kind of Medicare Advantage payment within the policy realm. But I think for enrollees, again, the most important thing I would say is to really look at your plans, shop around. If you don't take action, there's a possibility your premium can go up just because you haven't taken action. And of course, you would have gotten something in the mail about that, but I understand, folks get a lot of things in the mail, so that can be pretty complicated.
Gary, to you, I know you're a critic of the IRA, but as far as reaching people and telling them, educating them on these choices, what's the best way to get, whether that's in urban settings or low-income beneficiaries, to reduce the health disparities?
So I just want to be clear on what I said. So as I read the rule about the smoothing program, you get a bill and you have 15 days in which to pay. If you don't pay it in 30 days, you're cut off from that medication, not disenrolled from the Medicare program or the prescription drug program. It's that particular medication you cannot have access to until you pay the bill, right? And I'm not a lawyer, so I'm happy to have someone go take a look at the rule. But as I read the rule, if you don't pay within 30 days, then you're subject to lose access to that medication. Now, you may not want to call that a loan, but if it quacks like a duck and it walks like a duck, it's a duck. And that's the way I look at it. And the reason why I'm saying this is because in the moment of stress, people sign a lot of different things, right? They sign a lot of different things, particularly poor people. And if they can't fulfill the pledge, you got to understand the consequences. And so I'm happy to be wrong and love it to be wrong, but I think people have to understand deeply when they sign that piece of paper what that means to them and their access to their medication. On the $2,000, obviously, wonderful to have. But let's bear in mind that the average household income for a Medicare beneficiary is $25,000, right? And when you add up all those 20%, you go to your doctor, you pay 20%, you go to the hospital, you pay 20%. When you total that up on average, that's somewhere around $7,000 or $8,000 a year that a Medicare beneficiary, at least in fee-for-service, has to pay out of the household income of $25,000. So yes, you've given them $1,000 back. That's a wonderful thing. But that program is really burdensome, right? It is burdensome, particularly for poor people, because it's not means tested. So you're the CEO of Apple. You pay the same thing as the janitor. Come on, guys.
Well, there are low income folks that are on low income do receive assistance with their cost sharing.
Absolutely important. I think that's an important part of the program. I would expand that.
They did expand it in the IRA.
I would expand it even more, right? Because We have to means test it so that getting quality health care is not a burden to people. That's the point. It's the outcomes that we're trying to drive towards. And the system right now is rationing care.
But
I
it
mean, really
was
is.
rationing it. I mean, I think if we're talking about the IRA,
I'm talking about healthcare generally.
right? I know, but we're here talking about the IRA.
Okay.
I mean, and I think if you're talking about rationing healthcare, I think prior to the IRA, there was a situation where, and I was on the discussion with folks that have been, involved in legislation, and from my understanding, folks were calling, senators' offices saying, I can't afford my medicine. I have to, they were going without medicine, splitting their medicine. So that's rationing by another name. So if we're talking about the IRA and in terms of, and I granted there are, pros and cons. I don't mean to say that it's all, in one direction or another. But if you're talking about rationing, I do think that the IRA at least helps with that piece of it by making it affordable for people that had their medicines that were unaffordable. So I do think that's important to acknowledge.
I just add that there's no question that $2,000 is a lot of money for a lot of people, but I think this is a step in the right direction. And yes, we can do more. We can do more for people on Medicare. We can do more for people with commercial insurance. But I think for patients, especially those who are seriously ill, $2,000 may be better than $5,000, $10,000, $15,000 out of pocket that they needed to find. Just another comment on the Medicare prescription payment plan. I'm not a lawyer. I'm not reading it the way you are. If in receipt of that bill from the Part D plan, it's not paid within 2 months, then the Part D plan may, in fact, ask that individual to leave the Medicare prescription payment plan, but they're not going to kick them off of the Part D plan. That's how I'm interpreting it. And I think we have to remember that this payment option is not for everybody, right? I mean, everyone has the opportunity to review it and decide for themselves whether it's right for them, but it's especially helpful if that individual has spent or is spending more than $2,000, let's say in the first 9 months of the year, or they have a single prescription fill of $600 or more, or they don't want to pay everything up front in one lump sum. They would prefer to spread those costs out, or they're not eligible for the Extra Help program. And by the way, we have 3 to 4 million people in this country who are eligible for Extra Help and simply do not know that that program exists, or maybe they're not eligible for a grant from a foundation like the PAN Foundation. So it's not for everybody. It may be particularly helpful for 1 to 2 million individuals with high costs.
Julia?
I'll just add, as a part of the Inflation Reduction Act, this happened a little bit earlier, I believe last year, but there used to be partial and full Extra Help. And the Inflation Reduction Act actually expanded it, so all of those who originally qualified for partial Extra Help now qualify for full Extra Help.
Julia, I want to ask you a follow-up. You mentioned scams, and seniors are constantly targeted for scams, including Medicare scams. Has that been an obstacle? And ask you, but also weighing in with the other panelists, what would you like to see CMS do more of? Because, a lot of people don't answer their phone now, or they think, okay, maybe this is a scam. I haven't heard about this. It's not in the papers every day. What do you think about that?
Yeah, I mean, there's the trends are always changing, but there are a lot of there's a lot of scams in terms of people calling to offer free genetic testing or durable medical equipment. And I would actually say that there are a lot of concerted efforts across a lot of various federal agencies that are coordinating to try to make older adults aware that these scams are happening, helping them learn how to prevent it, and also getting the information that is needed so that they can be investigated or passed over to another federal agency to look across the aggregate in terms of the large trend that is happening and who needs to be held accountable to make it stop.
Anyone else who wants to weigh in on what the federal government could be doing more to say, hey, you've got to pay attention to this?
It's always difficult when we're here to talk about IRA, and I'm raising the broader issue of rationing in the healthcare system. But if you look at coverage with evidence determination, if you look at CBO scoring, if you look at the ESRD bundle, if you look at access to immune therapies, across the board for poor people, they don't have access to that stuff. Let's be really blunt about it. And so, yeah, you can do a $2,000 here, and you can do a little smoothing over there, but at the end of the day, their life expectancy is shorter. That's why we can go into a zip code and tell you how long you're going to live. That's why. Because the system is structured to ration care to poor people. Period. Not a lie, right? And what we're saying is we want evidence-based medicine for everybody. Everybody has to follow the science. You CMS, you Congress, you doctor, you patient, everybody follows the science. That is the best way to get outcomes for everybody, right? And we can pay for it because there's $4.5 trillion on the table, scheduled to be $6 trillion in 2030. That's a hell of a lot of money. Hell of a lot of money, right? For the kinds of outcomes that we are producing. It's unconscionable that we permit that. Unconscionable. That's my position.
Amy, what about the role of other stakeholders, providers? I know you have a guide on. Can you talk a little bit about that and their role in educating beneficiaries?
Yeah, I think several stakeholder groups are really critical to this equation. So we're trying to reach the person on Medicare, but that healthcare provider is a trusted source of information for that individual. So the healthcare providers, physicians, nurses, PAs, nurse practitioners, and so forth are in a wonderful position to make sure that the patients that they are caring for are aware that important Medicare reforms are coming their way. Working with community-based organizations, we're doing a lot of work at the community level, for example, in Atlanta and in Dallas, trying to collaborating with the local CMS office and educating the people in the community about the IRA in general and the Medicare reforms, because as I said, very, very low awareness. So I think to your question, we're all in this together, and there's a role for all of us to play in educating people on Medicare about, in particular, the Medicare prescription payment plan and the importance of open enrollment right now, which goes through December 7th.
Right.
Absolutely.
Just on
Yeah.
sort of on the education question. So as I mentioned, I was at CMS when the Medicare Modernization Act was passed, and sort of helped with the implementation of it. And I remember a story that was told to me by a colleague who somehow a phone call got sorted to him. I don't quite know how this happened, but at the time there was really a lot of, there was actually a bus. If we think back to like fall of 2005, there was a Medicare bus. There was a lot, Medicare.gov. There was a lot of advertising that CMS was doing around the Medicare drug benefit. And to the point that they had there was the Medicare blimp, which I think, if you guys remember that, which was actually at I think would be at like the SEC football games, right? And so what happened was, I think somebody called and was complaining because I was watching Alabama versus Auburn or whatever it was, Alabama versus Georgia, and I saw the blimp, and I'm like, why is the government spending money on this? And it somehow got to this person that I was working with. But I bring that up because I don't know that I've seen, and maybe it's coming, and I just haven't seen it yet. So I don't know this for certain. But we're in open enrollment now, and I don't feel like I'm seeing like that kind of educational push from the federal government around kind of pushing out. And maybe it's coming, and maybe I just haven't seen it. So I don't want to.
But it's getting late in the game.
But it's getting kind of late, and I don't feel like I've seen it. And I watch a lot of college football, and I just haven't seen it during college football games.
Seen it.
So I haven't seen it on Saturdays or Sundays, which is when obviously a lot of people are watching TV. So especially in this day of streaming and everything, it's kind of like the live sports is sort of the last sort of time to kind of get people where they're when they're actually in their seats. So I feel like that's something that I guess I would like to see more of. I think that's, I do think there's a risk for, people getting misinformation, people getting, scared about different aspects of it, and, making a decision that's maybe not well informed. And I do think that I'd like to see, sort of more from CMS here if I'm kind of thinking about what I think sort of needs to happen personally.
Because the blimps worked.
Well, I mean, it definitely, it worked. I mean,
we remember it 20 years ago.
We remember it 20-something years ago, right? I mean, remember that, and people probably remember the bus, and I realize some folks here, were probably pretty young when that was going on, but nonetheless, it was effective at the time, and I don't know that I'm seeing that kind of level of commitment, at least to an educational effort from this administration that I remember seeing from the what was at the time the George W. Bush administration.
I think you're right. Generally speaking, you're not seeing it. There are no blimps. And I'm skeptical that we will see much in coming months, which is why the Alliance for Aging Research and PAN and other groups are doing all we can to reach our stakeholder groups with this information, because it's important for them to have.
We will open it up for questions in just a bit. Obviously, the election is 2 weeks away. The IRA has been very polarizing on Capitol Hill, as I mentioned in my discussion with Bruce. Republicans want to repeal it, but that could prove to be difficult, and Republicans say they want to learn the lessons of Obamacare, which didn't work out so great for them when they tried to repeal that. Can anyone just talk about the noise, the polarization, and how that's affecting, and what will the election mean going forward, especially with a second round of negotiations?
I'm so glad you raised the question of elections, because in the community that I work in and live with, we've been put on a fire alarm. Democracy's at stake. You have to get in line. Everybody. If it's 2% difference, you're not doing your job. But then when we turn around to healthcare, right, and we look at those healthcare numbers, right, they don't reflect what you asked us to do. And the general feeling where I come from is that we're done with that. We want quality healthcare in our community. And that's why I'm saying to you, everybody has to follow the science. Everybody in the system, because if we do that, I think we get to equity. I think we get to where we want to be, right? Because the science is incredibly important. We are learning how to do fabulous things. What is going on in cancer? It's what Nixon imagined when he started the war on cancer. We are going to control cancer, period, flat out, right? But can we deliver that to marginalized communities? Not what we're doing right now. And so we feel reciprocity. We're going to vote, but come 2025, we want to see something different. And I think all Americans should ask that question, because that $4.5 trillion that everybody's talking about, that's your money. That's what every American household kicks into the kitty. It doesn't come out of the sky. It doesn't belong to anybody. It belongs to the American people. And then you turn around and say, well, we can't give you quality health care. We got the worst in the world. What the hell? Come on. You can't come back and say, I gave you $4.5 trillion, but you're going to die because I can't figure out how to get it to you. That's insanity. So in the communities that we work with, we're saying the moment of truth has arrived. We have lived with segregated health care since the American healthcare system was formed in the 1940s. We've lived with that. We know exactly what that looks like. And we're not doing that anymore. Right? So I'm just telling you how people feel, just being upfront with you. And that's what this election is about. Obviously, it's about our democracy, but it's also about making sure it's about social contract. You know, when Jefferson wrote Life, Liberty, The actual first word was conservation of life. That's our social contract. That's what we pledged to each other that we were going to do. And the moment is now to do that because we have the science and the capability. You don't even understand what we are capable of doing. It's unimaginable. Unimaginable. But we got this healthcare system, that healthcare financing system, that's really the problem, that can't really deliver the goods. So anyway, I'm going to stop.
Why don't we open it up for questions? We've got a mic. Just wait for the mic and just identify yourself and brief question.
Greg Pugh, I wanted to follow up on something Tom said. I was at HHS a little after you were, so I did not get on the Part D bus, but I did have the souvenir bus in my office. But I was there during the Affordable Care Act, and whatever you think about that, like I don't think that that's thought of as a public relations success necessarily, at least not in originally. And then 15 years later...
Not an implementation success either.
Yeah, right, fair. And then 15 years later, we're here and, 7, 8, 9, 10 out of 10 Americans don't know about this other thing. And so if Gary doesn't get his wish and we continue to have CMS messing around in the healthcare system and making these increasingly complex tweaks to the system around the edges that require a lot of patient knowledge that isn't... Do we need to rethink the whole paradigm of how people find out about this? Because, the work you guys are doing is great, but it doesn't seem like it's a sustainable way to do it.
This is my personal view. My personal view is I think when the government implements a policy, they need to lean into it and they need to follow through on it, right? And I think that's what, I don't know, it's my personal view. I'm not seeing that kind of commitment from CMS that I saw in the Medicare Part D program when it was implemented. Right, and I think it's unfortunate. I don't know why. I'm an independent consultant, not in the administration, but I feel like that's a missed opportunity. And I personally would like to see kind of more commitment. I don't know why that's not happening, but from my knowledge, I think that kind of. I didn't see that with the MMA. I saw, we passed this and it was controversial and, I think only in the House, I think voted mostly just Republican votes, right? So, it was seen as partisan in a lot of ways too, right? But, they leaned into it and they really kind of pushed it forward and they were not shy about, the kind of communication around it. And I don't know that I'm seeing that with the IRA. There are public information sessions, but in terms of the actual, beneficiary outreach and kind of a strong advertising, outreach here, I'm just not seeing it. And I was kind of waiting to see, will I see it? And, I don't think I'm going to. And I think it's unfortunate.
You will find information about the Medicare prescription payment plan on page 87 of the Medicare and You handbook. And I'm saying that facetiously. It's hard. It is hard to find, and maybe 1 out of 2 individuals on Medicare actually open up that handbook to review it. So to your point, I think you're right. It's more is needed.
It's hard to find on their website. Like it being the major issue right now. So sorry. Okay.
Hi, Rosamund Katz. I had been working in health policy in the federal government, but now I'm a volunteer at the Montgomery County SHIP office. So I really have learned to appreciate the difference between health at the 30,000-foot level, which is most of the people, and then really talking to beneficiaries every week. A couple of small things first is the $2,000 cap is on drug costs. It does not include premiums. Is my understanding.
Yes, that's right.
Drug cost Part D.
Drug cost Part D.
Right. This is in the standalone plans.
And the Medicare Advantage Part D plans too, right?
Right. And I don't know how many people are bumping up against the $2,000 maximum. There are a lot of people, I'd say the vast majority, whose drug costs are going to be far less than $2,000. So it's a policy. Everyone's going to think they've gotten this great gift, but it's not, doesn't really help them. It helps a select a few people. So the other thing is this MP3 business does not reduce costs. It spreads costs over 12 months instead of having it hit you in January and February. And a lot of these plans have $590 deductibles. Yeah. So that and high-tier medication is going to hurt some people, and this will help them smooth it out. If you are low income, the better thing is to seek the extra help, and that has become more generous over time. So that's on the technical things. But one point I wanted to convey is I talk to people, this is not only during open season, but throughout the year, and they say, why do I have to revisit this every year? I don't want to. I don't want to spend the time. I'm afraid of making a bad decision about my Medigap or my MA plan or something else. It's like homeowners insurance. You want to buy it and forget it. And here we are talking about spending more resources on educating people because of this instability, because everything is constantly in flux, and we're asking seniors and people with limited interest and ability to constantly make a really, really important decision for themselves.
Anyone want to? I just want to get to more questions. Yeah, anyone want to tackle that?
Yeah, I just want to say the average out-of-pocket cost that Medicare beneficiaries pay annually is somewhere around $700 to $800 a year. Some on average is what they're spending out of a total out-of-pocket of $8,000. Right, so that's the number that people are working with. And to your point, that's why the $2,000 doesn't really touch a lot of people.
But I'll add, while it doesn't, you're right, it doesn't touch everybody, but you never know when your healthcare provider is going to give you unfortunate news about a chronic disease. And so if and when that should happen, knowing that your out-of-pocket will be capped at $2,000 is a good thing.
And I do want to point out quickly, the Medicare Advantage plans do have a out-of-pocket limit. I don't remember what the maximum is. I feel like it's $8,900 or something, but that's on total medical costs. So there are protections in Medicare Advantage, at least on a Medicare out-of-pocket limit, and obviously the $2,000 out-of-pocket cap for the drug costs as well.
Go back of the room.
Good morning. Regarding public relations, I just wanted to bring a couple of things to the forefront. During the first open enrollment period of the Affordable Care Act, there were some fraudulent activity and some miscommunication to particularly marginalized communities. And so I want to know if there will be funding that will help to combat some of that kind of activity that could potentially take place targeting our elders as it pertains to this initiative. And if so, and one more thing I wanted to add, it was the navigators that you all funded who helped to educate and to bring to the attention of CMS that fraudulent activity that was taking place. And so I'd like to know if there will be funding as it pertains to Medicare, the Medicare drug benefit, so that there won't be this kind of activity taking advantage of our elderly population, particularly those in marginalized communities who were the most targeted. Thank you.
Anyone want to tackle that? Julia?
So for us, the Senior Medicare Patrol is a program dedicated to educating older adults about scams, fraud, and abuse, and then helping them report it. That's a program funded through the Administration for Community Living and works very closely with CMS and OIG in order to handle the cases of the issues on an individual level or on a broader aggregate level. So that program has been around for a while, and it continually adapts as these new scam activities evolve.
Yeah, one more question. I think one more.
Hi, Zach Schultz. I was wondering, we talked about the sort of the political implications with the election and going into next year. And I know there are efforts, particularly around reforming the small molecule, like how long before small molecule drugs can be included in the prescription drug negotiation. Do any of you foresee opportunities within Congress, regardless of how the election goes, to make tweaks to the IRA as we move forward?
Can I start? I feel like it's hard to predict what could happen until we know the outcome of the election. I think, just given kind of, House, Senate, White House, and in terms of, how the vote goes. So I think that'll, to me, sort of guide, obviously the Kamala Harris has talked about wanting to negotiate more medications. I know former President Trump's talked about negotiation in some form. So I feel like it's a little challenging to know kind of how that will play out until we sort of know the election, until we know broadly the election outcome. At least that's kind of my take on it.
Anyone else have a thought on?
The question you asked really cuts to the heart of the problem, really. When government steps in and starts setting price controls, you get all kind of oddities into the system. So small molecule versus large molecule. I mean, really, it's in my mind, it's like I go to a car dealer and the federal government is now setting the prices for cars, right? It's very, very difficult in an economy to set value outside of the competitive market space. And what CMS is doing, so it sets prices for hospitals, it sets prices for doctors, it now wants to set prices for drugs, right? And when you go and you look at what is happening, you see all of these inequalities, structural inequalities in the system because of the policy. And what adds to it is that CMS is not outcomes-based. It's not saying, am I reducing hospitalizations for people with diabetes? Am I using these new cancer therapies to increase life expectancy for people? It doesn't have those kinds of measurements. And we need those kinds of measurements down at the community level so that we can get the best possible outcome for patients. So I know I'm ranting and raving about government price controls, but there's a reason for it. Because when you go and you look at the data, you see year after year populations with shortened life expectancies, higher hospitalization rates, poor quality of life, right? For a program that we, the people, are paying for. And we're saying we don't want to do that anymore. We just don't want to do that. And we want to give ourselves permission to reimagine the system, because the question that you really should be asking, do you want this system in 2050? Is this what you want to have? Is this the conversation you want to have in 2050? I think that's ludicrous. Really, I really do. And so it'll be difficult, it'll be a journey, but I think we got to start the journey by saying to ourselves, we got to give ourselves space to reimagine. We want payers to help us reimagine. We want Medicare Advantage. Tell us what's going on. How can we help you? We want the doctors to reimagine. Tell us, what do you need, right? We want patient advocates to be at the table. That's our future. This stuff comes out of the 1920s. I mean, the 20th century, right? It's not 21st century medicine. Think about it. We could use AI. Do you want CMS using AI? Raise your hand if you want CMS using AI. Well, you don't. You don't want government in there doing God knows what. I'm just being candid with you. So when you look at the operating reality that we have, that system can't take us into the future. It's an old model.
We have run out of time. Please thank our panel for joining us this morning.
This concludes our program. I just wanted to thank all of our fantastic speakers and Bob for hosting. I also want to thank our sponsors, Alliance for Aging Research. And on behalf of the Alliance and the Hill, I'd like to thank all of you for attending, both in the room and online. If you missed any portion of this, everything can be found on thehill.com. Have a great day. Thank you.